Hi, everybody. Welcome to Talking Tuesdays with the Starch Queens. I'm Jeanne Schumacher, the Queen of Diamonds, and my partner, Nancy Matthews, the Queen of Hearts, and we together are the Starch Queens. Our online program provides coaching, recipes, and educational program that helps everyone to find weight loss success and healing. You can find our program at www.sqweightloss.com. So thank you. We have Dr. Duniaef here tonight, and he is joining us. He has medicalcompassmd.com. Thank you for taking the time to join us this evening.
You're welcome. It's my pleasure.
All right. Well, tonight, and also too, I forgot to introduce you, also have a basic program yourself where you're helping people to transition to a plant-based lifestyle. You have your office in Brooklyn. So
correct.
Yeah. All right. Well, tonight we have lots of questions, and we've posted them already, some of the ones that have already come in, but I'm sure there's going to be more coming in tonight in the live feed. So
do you mind if I just start with the topic?
Start with it. Our topic tonight is diabetes.
Okay. So when diabetes is mentioned, we have life-saving drugs to treat diabetes. And these are wonderful because many years ago, people would lose limbs, they'd lose vision, they'd lose their kidneys, they'd be on dialysis. And if it weren't for these life-saving drugs, they'd be in big trouble. However, diabetes is broken into microvascular and the macrovascular. And the microvascular means small vessel disease, and the macrovascular means large vessel disease. When you have microvascular, we're able to lower the sugars with these medications. But when we have the macrovascular, that's the cardiovascular disease risk. So when we lower the sugars, we're not reducing the risk of cardiovascular disease. We're not reducing it significantly. There is one medication that supposedly reduces risk about 30-something%, about 38% at most, but we're not really reducing risk tremendously. Whereas when you have lifestyle modifications with dietary changes, you can actually reduce the risk of not only diabetes and treat diabetes, but reverse diabetes and the complication of cardiovascular disease. Why is this significant? Because diabetes patients are at 2 times increased risk, or 100% increased risk of dying prematurely from cardiovascular disease.
Wait a minute. Did you just say 100%?
Wow.
100% increase.
Oh my gosh. Okay. Wow.
Right.
That's huge. That's huge.
Right. And it doesn't matter how much medication you put on. You do not really reduce this risk dramatically. And they used a trial called the Advanced trial and the Accord trial. The Accord trial had 10,000 plus patients in it, and so did the Advanced trial. And they were trying to get the A1C, which is the 3-month sugar, lower than, instead of 7, which is the mark that we use, we wanted to get it lower than 6 because we wanted to get people to be non-diabetic or non-diabetes level. And the problem was when they got down to about 6.4, 6.5, more patients died. So
how many medications did it take to get them
down to 6.4, 6.5? Great question. It took 4 medications. They had polypharmacy.
Yeah.
And that is what caused them potentially to die. Too many medications interacting.
Right.
So you can't do this with just medications. Now, interestingly, Dr. Neil Barnard had a study that compared to the American Diabetes Association, the diet he had compared to the American Diabetes Association, and that showed a reduction of A1C that was better than the American Diabetes Association, or ADA. It's much easier for me to say ADA than for clumsy American Diabetes Association. So I'm sorry for slurring that. But I did a study with Dr. Furman, Dr. Joel Furman, where we did a case series. So that means that it didn't have a control arm.
Mm-hmm.
And there were 13 patients. So it was not the optimal study. But what it showed was over 6 months, patients were on an average of 4 drugs, and they were able to get down to 1 drug. And that included diabetes drugs, but also cholesterol drugs and high blood pressure drugs.
Mm-hmm.
And their A1C was 8.3, and they were able to get down to 5.8, which is a considerable drop in sugars in a 6-month period.
When
Go
they
ahead.
did that, and they got down and they were still on one medication, typically what was that one medication? Was it like a diuretic? Was it?
It would be a blood pressure medication typically, but it could have been a cholesterol medication. But I've seen in my practice, I've been able to get people off medication, period. The borough president, Eric Adams' mother, was on 2 insulins and 2 other oral medications. And she was able to get off 2 insulins and 1 oral medication, and we're working on trying to get her off the last one. So it's not impossible to get people off medication. And I see it all the time where I'm able to get people off medication. I had this patient who came in who was 55 years old when he started with me, and everybody in his family died at the age of 57 from complications of cardiovascular disease and complications from diabetes, but diabetes and then the complications of cardiovascular disease. Let me rephrase that. So they died of diabetes or its complications. And he took on the lifestyle modifications, and he was able to get off insulin and his other drugs. And he was on about, I think, 5 or 6 drugs, and he was able to get off all of them. And his sugars stayed below 5.6 or 5.6 or lower. So he was non-diabetes. And he's done much better than his relatives, and he's been doing this for 5 years. And so he had a tremendous benefit by doing lifestyle modification. And there's story after story after story about people who can do really well with diabetes. The other thing is, people always talk about weight loss when it comes to diabetes. If you just lose the weight, the sugar will go down. Okay? And I've been saying for the longest time, that's not true. So I have this patient. She does everything I tell her to do. Everything. I'm emphasizing this because it's not exactly everything. But she does most of what I tell her to do. And in 6 weeks, she loses 18 pounds. Great, right? 6 weeks, a month and a half, 18 pounds. Nobody would complain about that, right?
Right.
We're in agreement? Okay. Her sugars, her A1C started at 9. You would think it would do really well. It went from 9 to 9.6. And she says to me, but I'm doing everything you told me to do. And I said, okay, so tell me what you're doing. And she said, well, for dinner, I'm having Chinese food. And I said, you're having the mixed vegetables? She says, yes. I said, you're not having much rice? She says, no. I said, okay, are you having this sauce on the side or are you having this sauce on it? And she says, well, I have the sauce on it. So she's injecting pure sugar into her veins. And the sugar from these Chinese sauces are so high that even though she loses 18 pounds, she still has her sugars go up instead of down. And so she has worse control. So it's not about the weight loss. Weight loss is only one component. Weight loss is important, but it's not just about the weight loss. So I think that's an important thing to bring up. And then and why are we talking about this? Because don't we have
you also have to reduce the fat.
Right. You also have to reduce the fat. Right, exactly. Yeah. But her fat came down. She lost significant amount of body fat, and she lost significant amount of weight. She lost 12 pounds of body fat.
Right.
But her sugar still went up from 9 to 9.6. That's what I'm telling you. She did really, really well. If you're looking at, I have a body analysis scale, and she did really well if you're looking at that number, but she didn't do well with her sugars.
Wow.
So weight is not the only factor. It's a contributing factor, but it's not the only factor. Now, why are we talking about this? Shouldn't diabetes be solved? Shouldn't we know all this? Well, in the last 20 years, diabetes has tripled in incidence. Tripled in the last 20 years. I mean, that is just amazing. Amazing.
Wow.
And then there's, can we prevent this from happening? with lifestyle modification? Well, there was the Adventist Health Study too. And the Adventist Health Study too, what was so great about it was it compared vegans to semi-vegans to to meat eaters. But all of them were pretty healthy. So all of them were doing a very good job. So it wasn't a comparison of just, say, a plant-based diet, a whole foods plant-based diet to the standard American diet. And we know when we compare that, right, we know when we compare that, we get results.
Right.
However, this was compared, this had meat eating, then had semi-vegetarian, they called it, then it had pesco-vegetarian, which meant fish, then it had lacto-ovo, which meant dairy and egg, and then it had vegan. And what we saw in the study...
Wait, let me guess. Vegan was the best?
Vegan was the best with diabetes. How'd you know?
I know.
Vegan reduced the risk by 62%
wow.
of having diabetes.
Wow.
Right. And when you think about that, 62% is pretty good. And this wasn't a study geared toward that, but this was a study looking at it through an observational and looking at the data. Right. But it was a large study using the Seventh-day Adventists. That's why I was having trouble saying Adventist without the seventh, because I'm used to saying Seventh-day Adventists. But anyway, I just thought that was really interesting information.
That is powerful.
Right. And here's another one. Here's another one that's very powerful. When patients have diabetes, we used to give them 3 to 6 months for diet and lifestyle modifications. Now we give them metformin and insulin. So we give them presence of medication right off the bat. Why? Because they're going to fail diet. That's what we assume. And you know what happens when we assume, right? So,
but we want to keep this a family show, so
right.
We won't say what that is, but
we don't need to go into details about that. But what happens? They give them medication, and it turns out that the reason they do this is that physicians and providers say that patients will fail diet, and it's not that patients necessarily fail diet. It's that physicians fail patients because they don't arm them with the tools that they need. Physicians may not have the rudimentary understanding of what goes into lifestyle modification or where to refer to people who specialize in lifestyle medicine. And that's the disadvantage that occurs. So when the patient comes in, they say, oh yeah, you need to go on diet and exercise, and here's your medication. And the patient says, what about diet and exercise? And they said, do it. Change your diet. But they don't really know what it means, and they don't really know what we know, right, or what to do. So they need a rudimentary understanding, more and more physicians, or at least they need to know where to refer. Physicians who specialize in lifestyle modifications, what we call lifestyle medicine. And there are a bunch of us, and then we're across the country. So it's like referring to an endocrinologist, referring to a rheumatologist, referring to an ophthalmologist, referring to a cardiologist. You refer. If you don't know, you refer, but you find someone to refer to. And it's very important that physicians understand that lifestyle medicine exists, and that it's not just in the fringe, but that it's in the mainstream research. It's in journals like the New England Journal of Medicine. It's in journals like JAMA. It's in the Lancet, which is the British version of the New England Journal of Medicine. So there's so many popular journals and so many important journals that have been publishing these articles showing all these benefits. And so we really need to make sure that we can have a presence in the guidelines and suggest, instead of putting people on medication, we give them more time, and we find people who can help them.
And you need to clarify, because what we need to be eating is whole food plant-based. Because if you look at whole food plant-based versus vegan, I mean, Oreos and Coca-Cola are vegan, and I think we can safely say those are not health foods. And if you're going to consume,
they're not.
Yeah, right. I know. Flash. You know. I mean,
right. I totally agree. And there was a study done that took vegans and compared them to meat-eating population. And what they found with this was with coronary heart disease. And what they found was that the meat-eating population, not surprisingly, had an increased risk of coronary heart disease significantly. And the vegan population had a decreased risk of coronary heart disease. But what they did that was even better was they delineated between healthy vegan and unhealthy vegan. And when they separated that out, the healthy vegan, what we call whole foods plant-based diet or nutrient-dense diet or flexitarian or whatever term you want to use, but it means using a lot of plants. When they delineated that out, they found that the healthy vegans dropped their risk significantly more, and that the unhealthy vegans were equal, if not worse, than the meat-eating population, which came as a huge surprise. So vegan doesn't mean or equate to health.
Right. Nope.
Got to be whole food plant-based.
Whole food plant-based all the way. I mean,
right.
No fat, no oil, no processed foods. So I hope that Mary McClintock, who's watching with us, she asked real quick, can chemo bring on diabetes, or will sticking to a vegan diet help?
Can chemo bring on diabetes?
Yes.
Well, first of all, not necessarily. I mean, chemo has weird aspects. And if you're working on the pancreas, potentially, you never know what chemo can do. But I don't know that I've seen cases where chemo has brought on directly diabetes. However, we don't really know. We know that chemo can bring on peripheral neuropathy, where you lose feeling in your feet and you have tingling and numbness, similar to when you have uncontrolled diabetes. But I don't know that diabetes can be brought on by chemo. But diabetes can be brought on by people who drink a lot of alcohol. And that's not because the alcohol has so much sugar, it's because the alcohol affects the liver in a negative way.
Wow. So would you clarify, Dr. Duniaef, what is your definition of a lot of alcohol? Is that your teetotaler who has a beer every night, or is that somebody who's having a 6-pack or a 12-pack every night, or a couple highballs a day?
So when you say a lot, for a woman, more than a beer or more than an alcoholic drink, one alcoholic drink is too much.
Wow.
That's what the research suggests. For men, it's 2 drinks a night. And you're better off really, and you're better off really having it maybe 2 or 3 times a week at most, rather than having it every night. And you're also better off, especially if you're prone to diabetes, not having beer, because most beers are based on wheat. And so that can raise your sugar. And so if you have something like vodka or something like that, you're more likely to reduce the risk of diabetes rather than increase the risk by having a beer.
Right.
So the drink matters what it is as well.
Right.
Let me jump in and ask a question. Lisa Sim wanted to know, she said, my grandmother died of a diabetic coma, and me being obese, is diabetes something that I must watch out for?
Well, your grandmother died of a diabetic coma. So by definition, you need to watch out, period. But being obese fuels the fire. I mean, it makes for increased risk. The diabetes, the weight may not be the only risk factor. And that was what I was trying to say. When you lose 18 pounds and yet the sugars still went up, it means that weight isn't the only risk factor. But having more weight on your body, having excess fat, it's not the weight, it's the excess fat. Right. And having more excess fat can cause inflammation, which can cause the endothelium to be dysfunctional, which can cause high blood pressure, can cause cholesterol. And then you notice that a lot of times, or I notice a lot of times, diabetes patients also have high blood pressure and high cholesterol. And it's not a coincidence, because it's affecting a lot of organs. It's affecting the liver. It's affecting your blood vessels. It's affecting your pancreas. And the more fat you have, the more likely you are to negatively affect organs. So if you have visceral fat, which is fat around the organs, not the fat below the skin called subcutaneous fat, but visceral fat, the fat that goes around the heart, around the liver, around the pancreas, and that type of fat around all of those organs can cause increased risk of diabetes. But her family history also is a contributing factor. So she has double whammy. Should she be watching out? Absolutely. But she shouldn't just be watching out. She should be actively trying to prevent it.
And she is. She's part of our Starch Queens program, and she has been doing a phenomenal job. As a matter of fact, she posted, she's gone down quite a few dress sizes. And
that's great.
Yeah, no, she's on a roll, and she is doing everything right. I mean, she is plant-based, 100%, no oil, and everything has been coming down. So,
okay.
I have something for you, Dr. Duniaef. Have you heard the term skinny obese?
Skinny obese?
Skinny obese. So my grandfather was, 6'2", 6'1", somewhere in there, and then my uncle about the same thing. They were both very slim.
Oh, wait. We have a different term for it.
What's your term?
It's called a TOFI. Thin on the outside, fat on the inside.
All right.
A TOFI? How do you spell that?
How do you spell that?
TOFI. TOFI. Thin on the outside, fat on the inside.
Okay.
Is that a technical term?
I love it.
And my scale has another term for it. My scale has another term for it called hidden obesity. I think that's even a better term.
That's a good one.
I like that one.
And that really is what it is. It's hidden obesity. And that's really dangerous. And people walk around thinking they're doing really well, or they can eat anything they want. And it turns out that they have high amount of fat in their body. And it may not even be that they're over the range of normal range, but because their body has such light weight, percentage-wise, their BMI may be really low, but their fat percent may be on the high end. And that's not what you expect. You expect the fat percent to be on the low end if the BMI is on the low end of the BMI scale.
Right, and both of them, my grandfather actually had type 2 diabetes that he developed in his 60s. He passed away when he was 71 or 72. Like Lisa, he was, there was a whole kaleidoscope of different health issues, but it started with diabetes. I call it diabetes, but he was never overweight. But he ended up taking insulin, macronase, but it was 2 fried eggs and bacon every morning and a slice of white toast. Same with my uncle, and then my uncle died of cancer. But both of them were slim, and when you were to look at them on the outside, they were both very healthy, but they both suffered from type 2 diabetes. So you don't have to be heavy on the outside to have diabetes.
Correct.
All right, we have another question from Sandra Garber. She said, are meds like metformin helpful when early in your whole food plant-based, no oil, no sugar diet? I've lost 20 pounds over the last month, but my glucose level goes up to sometimes over 300 after eating fruit, potatoes, or whole grains. My morning levels are an average of 180. I am obese and have no diabetes in my family. My last A1C was 8.3.
Okay, well, you have diabetes now, so you now have diabetes in your family because you're part of your family. So,
no, this is a different person. This is a different question.
No, I'm saying now it's part of your family history because you are making it part of your family history. You're the one with the diabetes, having the hemoglobin A1C of 8.3.
Right.
So what's the question again? I'm sorry. Just
so basically, are meds like metformin helpful in the beginning of the stage? Because she's just starting her whole food plant-based journey. So
metformin can be helpful. Sure, metformin isn't a bad thing to start. But if you can do a plant-based diet and do it for 3 to 6 months without meds and see how you do, that's great. But ask your doctor. And if your doctor's suggesting metformin and the guidelines suggest metformin, ask your doctor and see what he or she thinks. So I'm not saying do this, do that. I can't say that because you're not my patient and I don't know anything about you except for what I was just told by Jeanne, and she did such a wonderful job. Right. Give yourself a little pause. Right. Pat yourself on the back. Okay, good. We've got it all down.
All right.
So I would say metformin wouldn't be a bad thing to use to lower the A1C for the short term, I would think of diabetes drugs for the short term. So if you use, or any drug, I would think of it as we want to treat an acute disease. And when it becomes chronic, you want to use the lifestyle to control it. You want to use drugs as an acute process. In other words, you're just using it for a bridge to get to the point where you're under control, and then the diet takes over, and now you don't need that drug, and now you can be weaned off. I mean, would you take an antibiotic for the rest of your life? You wouldn't think about it. That would be an odd thing to do unless there was some kind of weird scenario. But you wouldn't take an antibiotic. Go ahead.
Well, this ties in totally with the question, one of the questions we have tonight on the agenda. And Mary Davis says her doctor wants her to go on several medications, but she wanted to know your thoughts on the long-term effects of taking medication for the short term in general. So this ties in perfectly.
Okay, so she wants to know what the long-term effects are?
Right, of taking a medication for short term. So
if you take a medication for short term, then it fits within the realm of what we see in the package insert. The problem becomes when you take a medication, say you take a drug like metformin for 20 years, or you take a proton pump inhibitor for reflux disease for 20 years or more, you start to find weird things that occur. You start to find unusual side effects. And the reason for that is the package insert only went to 2 years or so. And then there's no study. So what you're seeing is empirical data. You're seeing just purely individual data reporting in that this causes lactic acidosis with metformin, or it causes other common side effects, but you see them sometimes 20 years out. And what I find is that patients say, but I've been on this drug for 20 years with no side effects. How could I have side effects now? Well, the side effects can be worse the longer you take a drug. Initially, the initial side effects usually are minimal unless you have an allergic reaction, and then they can be deadly. But usually the short-term side effects are minimal. The long-term side effects can be much worse than the short-term side effects. So if you're taking a drug within the package insert of what the trial showed, you're well within the realm of what they've seen in the trial. So your side effects shouldn't be any worse than what the trial results showed.
Okay.
Very good. Well, we have another question, Dr. Duniaef. Lisa M. asks, conventional medicine takes a reductionist approach. I have heard this term, but what does this mean and how does it affect me?
Okay. So reductionist approach is the way we always have looked at drugs. So we look at a drug and we say that this drug is to treat diabetes. So we want to lower the sugars. And so what we do is we give them a large dose of this type of drug to help lower the sugars by working on the pancreas, or whether it's working on the liver, or whether it's working on the insulin so that it gets absorbed into the muscle, the sugar gets absorbed into the muscle, whatever it happens to be, or whether it's peeing it out, excreting it out, using another new class of diabetes drugs. But what we do is we give them a megadose compared to what you could get in food. And you can't get this stuff in food mainly, but we give a megadose of medication. And we do the same thing with supplements. And we do the same thing with nutrients. So if you take beta-carotene, we thought beta-carotene would prevent lung cancer or would help reduce the risk of lung cancer in smokers. What did it do? It increased the risk of lung cancer because we thought that beta-carotene was the main element in plants. And it turns out there's so many phytochemicals in plants, and there are 600 plus carotenoids. We don't know which ones were doing what and in what balance.
And if they are symbiotic with each other.
Right. Right. So when there's a symbiosis, and we don't know what type of symbiosis it may be mutualistic, it may not be, but you need that relationship to exist. Symbiosis means relationship, and you need that relationship to exist. And many times we use it in a pejorative way to say symbiosis means mutually symbiotic. But mutually symbiotic is not the same thing as symbiosis. But there is a relationship and the symbiosis. We just don't know what kind of relationship there is, and we don't really understand it. And then what we do is we look at nutrients instead of looking at foods. So in other words, we say, okay, we need vitamin C. So let's take mega doses of vitamin C.
Right.
We need sodium. So let's take mega doses of sodium. We need potassium. So let's take a potassium pill. So let's take 20 milliequivalents of potassium and find out what happens when we do that. And it throws things off instead of saying, okay, what foods contain potassium? What else do they contain? You see what I'm saying? So you break it down into that individual item rather than the thousands of compounds that are in plants.
Well, I got an analogy that I use when we were talking about this. And one is my son who played the baritone. Oh my God. Wow. We would send him to the basement because it was, he had the theme down for Jaws, dun 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 dun. He could play that. That was good. And then that was it. And then it was painful, the rest of it. But when he got in with the symphony, all the symphony playing together, it sounded beautiful, with the baritone in there. But take that baritone out, and wow, we needed earplugs. And that's kind of what we're doing when we take things out, like a vitamin C component. We're taking the baritone out and having to do that and listen to that. So
right.
That's my analogy.
Right. It's like making us, and there's nothing wrong with a soloist in the band, but the soloist by itself doesn't make the orchestra or the band or the ensemble or whichever term you want to use. So you need the players. It's just another analogy. Let's use something that people can relate to, I think, is baseball, maybe, potentially, where you have 9 men on the field. You take everybody off except for the pitcher. Now the pitcher's throwing to the wall, not even to the catcher, and you have a batter. So you have a batter and a pitcher. Now where's the ball go? And who's going to field it? And now you don't have a game. You just have a ball, a bat, and someone throwing it to you. And we don't call that baseball. We call that batting practice.
That's a good one.
That's a good one.
Yeah.
Yep. It's like removing the oil from the olive. Without you're removing the oil, you're removing the fiber, all of the micronutrients that come with it.
And the protein. Yeah,
and sure. The protein, all of that. So that's a great question. That's a really good question.
Right. So don't have a reductionist approach.
Right.
You should have a whole body perspective. You should have a holistic whole body. I was getting there. Yes. A holistic approach where you're looking at food, not nutrients. Now you want foods that have lots of nutrients, but you don't want nutrients by themselves necessarily. So that means I'm not. Right. And that means I'm not really, and you guys probably agree, I'm not really a big proponent of supplements unless you're really low in something, because supplements are mega doses of one nutrient.
Right.
Yep, exactly.
All right. We got another question up. This is from LaRay, Seier, and I'm not sure I'm saying the name right, but she's our admin for PlantBased Tullahoma, Tennessee. So shout out to you tonight. She says, are there any easy tips to transition to a plant-based for diabetics? How do they manage their blood sugars to ensure stable levels? Most I speak with ask what to eat and how much. They're so used to counting carbs and calories. So would they just follow the same process as others and just eat the colors of the rainbow, increase fiber intake? What about fruits? How do they incorporate this at meals? Are there certain fruits to limit or avoid?
Okay, that's a really good question, except it's really not one question. It's like a host of questions, and we can answer about an hour of it. But let me try.
Stay tuned, everybody. We got a lot coming at you.
Right. Let me try to synopsize here. First of all, the difference between, and this brings up a good point, and I'm going to be maybe a little tangential here, but this brings up not me. I'm known for tangentiality, and that's a sign of I'm not sure what, but we could make up a disease. Actually, it's a sign of dementia, supposedly, with the more tangential you are, but that's actually not true. So there's really no relevance to it. Actually, let me just go off on another tangent. 1 second. There was a study done in 1970s that said that lefties die earlier, have a shorter lifespan.
Don't tell that to my husband.
And well, I'm a lefty. My wife is a lefty. My wife's mother is a lefty. Are we interrupting your calls? Are we in? Is this the operator? Did we reach the operator?
One ringy dingy.
Oh my God.
Very good. So this study showed that lefties had a shorter lifespan. And it turned out this was done during the industrial age. And all the equipment was made for righties. So lefties, when they would use the equipment, would cut off an arm, would get impaled by the machine. So they would die more frequently than righties. So, but there's a point I'm making here, and that is that when you look at the standard American diet and you say, okay, what's the best part of the standard American diet? The calories. We look at the calories, and what we do is we try to restrict the amount of calories, because people do much better when you restrict the amount of calories down to 800 and lower down to 500. And they call that intermittent fasting, because 500 calories is intermittent fasting, even though it's not, because it's still 500 calories of food. And you could compare that to the whole foods plant-based diet or the nutrient-dense diet, and the focus is on nutrients, food with nutrients in it. And so what is it about? It's about eating volume. So the more food you eat, the better you do. And so why is there a difference? Why do you want to calorie restrict with the standard American diet? Why do you want to eat more volume with the plant-based, the whole foods plant-based diet or the nutrient-dense diet? Well, with a standard American diet, you're trying to restrict the toxins. Right. By taking away the toxic food, you allow the body to repair more. Whereas with the whole foods plant-based diet, the food is so valuable with the nutrients that it enhances the body's repair. So the more you eat, the better you do.
Those leafy greens, got to get those leafy greens in.
Those leafy greens. So it's really important. And, you know, it stands for dark green leafy vegetables that are so important, DGLVs, or as one patient said, because I'll keep it G-rated, darn good leafy vegetables.
Okay. All right.
But in terms of answering her question, in changing things, well, one thing you can do is really reduce the amount of sugars you take in. But sugars can be hidden in
so many things.
Starches and in starchy vegetables and things like that. You got to be careful with that. And in grains. And so you have to be really careful with that. I find it plays a big impact. And there is research that says that too much fat can play a role as well. And so you want to be careful of too much fat. But getting the inflammation down is a big factor as well. So those are the components that you want to look at with diabetes.
Well, I'm going to jump in with another question. Teresa Adams wants to know, what is the long-term effects of statin drugs
and heart disease?
And heart disease.
The long-term effects of statins in heart disease. Well, the long-term effects of that's a tough question to answer. And the reason that it's a tough question to answer is that, are you talking about primary prevention of heart disease, or are you talking about secondary prevention?
I think that she's just asking on the body, what are the long-term effects on the body of statin?
Right. But the benefit of a statin is more beneficial for people who already have heart disease to prevent more heart disease. It's not great, but in primary prevention, it's not even sure if it really works, if it's just the cholesterol levels. However, the impact it has, well, it can play neuromuscular issues where you have pain in your legs and you have pain in your arms and you can have breakdown. You can have an increased risk of diabetes of 40+%, about 46%. Believe it or not, diabetes, statins. Statins increase the risk of diabetes. Also, statins, the long-term risk of statins is that people use statins to eat really poorly. There are studies that show that people who take statins eat much worse than people who don't. Another long-term risk of statins is that it covers over that you need to lose weight, and it tells you, it almost instructs you, that the lipid profile instructs you on how to lose that weight. So if you have too much triglyceride, that means you're having too many sugars. And if you have too much LDL, the bad cholesterol, that means you're having too much fat. It's like a map to how to lose weight. When people say, I don't know how to lose weight, I don't know, is it the fat? Is it the sugar? Is it the metabolism? It's a combination. But when you look at those numbers, they're covered over by a statin. So does a statin protect you? Well, we think so. But for the long term, it may be beneficial for some people. But it depends on how you're eating. And if you eat really well, you can do really well. But Dr. Caldwell Esselstyn took 24 of his patients, and 18 stayed on the diet for 5 years and then went on to stay on the diet for 12 years. And these patients were very special because they had had 50 plus cardiovascular events before going on the lifestyle. So they had coronary heart disease and they were very bad off. Some of them were put on statins, 5 milligrams of rosuvastatin, and others were not. But it really was preference. But they were all put on a plant-based diet. And the ones who stayed on the plant-based diet, and there were 18 of them, there were no events, no cardiovascular events for the 12 years that they were on this diet. And the 6 that fell off the diet in the first year or so had a number of cardiovascular events all of a sudden. So that plant-based was huge. Now that statin might have helped some patients. Now, fast forward, he did it with 198 patients without statins, and they did well. And the ones that fell off, there were 21 that fell off in a 3.5-year period. And of the 21 that fell off, there were 13 events. 13 had cardiovascular events out of 21.
Wow.
177. Of the 177 that stayed on the plant-based diet, one had an event. That means 0.6% of patients had an event. Whereas with the people who fell off, more than 60% of people had an event.
You can't argue with those numbers, but like you said, Dr. Duniaef, with my dad, with my personal experience, is truly my opinion is that the statins truly give, like my dad said, he's like, I'll just take my cholesterol pill and I'm going to go eat at the restaurant and have whatever I want. It's like a get out of jail free card. But of course he had, 2 open heart surgeries, congestive heart failure. He had terrible heart disease.
And there's your answer.
He was continually prescribed a higher dosage of Lipitor, but he also had the terrible side effects. He had polymyalgia, he had muscle aches, and just terrible side effects from it. But it wasn't so bad that it prevented him from looking at diet and lifestyle changes. He just wouldn't go there.
Right. So you have those muscular issues, and you have those diabetes issues, and you have potentially memory issues. And there are a lot of side effects from drugs, and statins have a bunch of them, and statins aren't free of side effects. And as you can see, he still had the heart attacks with the statin.
Yeah, no,
he did. It didn't matter whether you had the statin or not, necessarily. And it's not a guarantee that it's going to keep you from having a heart attack. It's not a guard against a heart attack. And what people forget is that we give aspirin, for instance, to prevent a stroke, and it reduces the risk of stroke by 20%, which means that, so you have 5 strokes, one of them's free. You won't have to have that one stroke, but the other 4 you have, and you get the 5th night free. It's kind of like,
wow.
Yeah, so it really did nothing to prevent my dad from having severe heart disease and then dying from cancer. So
what it did was worse.
It did nothing. It was worse. Because quality of life was terrible. His whole body hurt all the time. He had a terrible side effects and they tried different statins, and this was, a long time ago. So there was pretty much was, like 25 years ago when they kind of first started coming around, and it didn't do anything. It didn't do one thing to extend the course of his life or improve his life. Actually made his quality of life worse.
Right.
Yeah. Right. We have another question for you, Dr. Duniaef. Beth Kramer, who's a member of our Rabbi Beth Kramer, is a member of our Starch Beans program, and she asks, what are your thoughts on the benefits of raw foods versus cooked? Is it worth the extra effort to do more raw, or is it really just not a big deal?
The answer is they're both good. And they're both good for different reasons.
Right.
And if you have, say, cancer, raw food would be better than cooked food. Now that I'll give you a caveat on that though. If you chop up the raw food into little pieces and then cook it, then you can have cooked food as well. But if you chop it up, then you allow the enzymes to be released, and then you get the nutrients like the isothiocyanates and the 5-indoles. You get all those benefits when you chop it up. Now, if you have inflammatory bowel disease, like Crohn's or ulcerative colitis, if you have a lot of raw foods, at least at first, it's going to be so painful. It's going to be so painful. You're going to be cursing out everybody because you're not going to want to eat raw foods, or even irritable bowel syndrome. So it depends on what's your situation. And if you have neither, and you have neither problem, and you're just trying to prevent things, then a combination of raw and cooked is a good combination, because raw goes through your system really fast. It's like going down a really steep slide. And cooked goes through much slower. So you get different nutrients. So cooking is great. Raw is great. They're both great. Even having smoothies where you break it down so it's emulsified, the raw, is a different effect than raw without breaking it down compared to cooked. And then if you get frozen, what's frozen? It's cooked. Frozen is cooked. So if you want frozen vegetables, that's good too. And people are always worried about frozen vegetables. And now let me get back to a question that I never answered with the 500 questions. That was one question that Jeanne asked that had 500 parts. Did you ever see the movie Back to School?
Multiple questions.
Did you ever see Back to School?
No.
Oh, yeah.
With Rodney Dangerfield?
Yeah.
Where the guy wants him to... Where the guy wants him to fail at the end, and he says, "I only have one question," and he goes, "Phew, with 26 parts." That's like what you did. But as far as fruit goes, we used to think that fruit would cause the sugars to go up, and that bananas were bad, and that it really had to do with the glycemic load. And it's not necessarily true. What I see in the clinic, for instance, is that bananas, with a diabetes patient, he said, "Could I have 8 to 10 bananas a day?" Now, he had PTSD. He was using the bananas to chomp on instead of break somebody's leg.
Wow.
And he was a first responder, so you got to give him a lot of credit. He had PTSD from 9/11.
Okay.
Wow.
Right. So got to give him a lot of credit. I said, "I don't know. Why don't you do it and let's see what happened?" Well, he was having 8 to 10 bananas a day. And his sugars, and he was a diabetes patient, and his sugars went up 0.5%. So it went up 0.5%. So I said, okay, you have to bring it down. So what was he eating normally instead of 8 to 10 bananas? 4 to 5 bananas, and his sugars came right back down. So the moral of the story is he could have 4 to 5 bananas, but no more. Who eats 8 to 10 bananas a day for a month? Have you ever tried to eat a bunch of bananas? I've eaten a bunch of bananas, having been dared doing it as a kid, saying that I was a gorilla or something like that, but I only did it once. And then I was so full, I felt like I was going to explode. So the moral of the story is that fruit really doesn't raise your sugars. In fact, fruit reduces the risk of diabetes by about 20 to 25%.
That's huge.
And we have this aversion to it. But fruit juice and dried fruit is not the same as intact fruit.
Doesn't have the water.
Nope.
Doesn't have, well, the dried fruit takes out the water. The dried fruit is shrunken down. It's more concentrated. It's getting close to sugar. Right. And the fruit juice obviously is just the sugar and doesn't have the fiber, doesn't have the protein, doesn't have the same nutrients.
Right.
I've got a question from Susan Cooper. She's one of our Starch Queens ladies. And she says, can diabetes hide? She says, can it be masked by something else? Like her A1C is 5.5 and her doc said everything's normal. So she's keeping it under control. But does it mean she still has it?
Well, she's not on any medication for diabetes.
Right.
Or is she?
Not now.
No, she doesn't have any diabetes now.
No.
Okay. So, and did she ever have diabetes?
Yes.
Okay, because it wasn't clear by what you were saying whether she had diabetes or she didn't have diabetes to be.
She's had it and it's now under control. Okay. But the question, I guess, is, does she still have diabetes?
Well, she's always going to have diabetes. She's always going to be a patient with diabetes. She's not a diabetic because diabetic is defining by the disease, but she's a patient with diabetes. She's a patient who has it under control without medication, which is wonderful. So she's on non-diabetic levels, but she's always going to have diabetes. And why I say that is you're reversing disease. You're not curing disease. So reversal means that you can reverse what's happening, but if you go back to what you were doing before, if you go back to that lifestyle, the standard American diet, or any diet high in sugars, you're going to end up with diabetes again.
Right.
Out of control.
That's exactly my viewpoint. Even though Jeanne and I have lost so much weight each, the moment I take one step to the left of this lifestyle, I'm going to regain my fatty liver syndrome and everything I've reversed, but it's not a cure. We are all subject to the same outcome if we go back to eating the standard American.
But think about how great that really is, because your body is forcing you to do what's right.
Exactly. I wouldn't, it's a non-issue for me. I will never.
And when you're obese, think about how lucky you are. Well, you just talked about hidden obesity. Think about how lucky you are that when you're obese, your body's telling you you're consuming too much. And that obesity is brought on, and then you're eating more. And so you eat more, and obesity causes you to eat more. I was just at a lifestyle medicine conference this week in Boston. Actually, last week in Boston. I don't know which week it is. But
summer.
They were talking about how obesity causes people to overeat, not overeating causes obesity. So that's a really important distinction in the fact that when you get obese, you feel like you need to eat more because you need to feed a bigger body. But in terms of sugars, or in terms of A1C and being able to tell if you have hidden sugars and what's going on, you could get your insulin levels checked. And if your insulin levels are normal, and your A1C is normal and your fasting blood sugar is normal, then there's no hidden sugars, but you can check the insulin levels. That's another way to check. You can also check the fructosamine. Fructosamine is between a 1 and 3 week measurement of sugars. So you've got the 1 day sugar with a fasting blood sugar. You've got the 3-month sugar with the hemoglobin A1C. You've got the fructosamine, which is 1 to 3 weeks. And then you've got the triglycerides, which are between usually 4 to 5 days. So you can measure all different levels to tell yourself how you're doing. And they're independent and they correlate with each other. And then you can also test your urine. And if you test your urine and there's glucose in your urine, sugar in your urine, or there's protein in your urine, and it's related to diabetes being out of control, then you can see that also, and ketones as well. So you can look at your urine as well. So there's a number of ways to look at it. But if all those things are clean, most likely with a hemoglobin A1C of 5.5 and eating really well, you don't have any hidden
issues.
That's awesome. Good.
Yeah.
Are there test strips for those, Dr. Duniaef? Can you just go to your pharmacy and get a little test strip that tests for glucose, or you need to see your doctor?
Not in detail.
Okay, so you need to see your doctor.
Do a urinalysis to do that. That's more complicated than a pH strip and stuff like that.
Gotcha. Well, I do want to compliment Susan, the same person who asked this question. She's been in our program since January 1st. So she has 2 rings that she has not been able to wear for 5 years. She has put them on today on her finger for the first time in 5 years. So she's doing wonderful. And that's one of the non-scale victories that 3 of our members in our group now have experienced. They're able to wear their blingy jewelry again. Isn't that nice?
That's called lifestyle at its best.
It is. Who doesn't want to wear diamonds and gems and gold? So we're really proud of you, Susan. Congratulations. That makes me want to cry. Just love Susan. It's wonderful.
That's why you're the Starch Queen of Hearts.
Yeah. You know me. I cry. But anyway, congratulations, Susan. We're going to keep you going all the way to get all your rings on your fingers. So we have another question from Freddie Muntz. Can symptoms like tingling in the leg and foot start before diabetes, show up in the numbers found on the That does make sense. Freddie says, can symptoms like tingling in the leg and foot start before diabetes?
So if she has tingling in her leg and feet, could that be a pre-symptom of diabetes? Like your tests come out, like your A1C test comes out fine, but you've got some tingling. Could that be a precursor to diabetes?
Well, could neuropathy, pain, like tingling like that be a symptom of something other than diabetes?
Answer is that when you have controlled A1C, the likelihood of the tingling and numbness being from diabetes is really low. So that's microvascular disease, and that's really based purely on the sugars in that case. When numbness and tingling occurs, it's idiopathic is the number one cause, which means we don't know what the cause is. Isn't that wonderful? And the second most is diabetes, and the third is impingement on the spinal cord. And so you get numbness and tingling. And so you don't really know what the cause is. It's kind of like if you have blood in your urine and you say, oh my God, we used to think blood in your urine, it means I have renal carcinoma, which is to say kidney cancer. But it may be a kidney stone, or it may be spotting during your period, or it may be due to an irritation that's occurred, or it may be due to an UTI that occurred that caused the lining to slough off or something in your bladder. So the number of things, or it may be from damage from working out or something like that.
So you have to figure out what the cause is.
Right.
That's the bottom line. Okay, we
Yes.
have
See your doctor.
See your doctor.
Yeah.
Anita Hill, another one of our Starch Queens members, asks, she wants to know about taking diuretics for high blood pressure, and how does it affect the kidneys long term? And do we become dependent on taking diuretics?
Well, it's a great question. And diuretics are water pills, so everybody knows. And what diuretics do is they squeeze out the water from your system. And so that lowers your blood pressure. And so in some ways, people have said that diuretics are great drugs because they're simple and they don't have many side effects. But what I find is that diuretics increase the risk for acute and chronic kidney disease. So if you want to cause more problems with your kidneys, diuretics are the way to go. Now, some people never get affected, but most people, when they dry out their kidneys, are you okay?
I'm okay.
Okay. Most people, when they dry out their kidneys, see the functioning go down. There's a direct relationship to the functioning. It goes down as they dry it out, and it goes up as they keep it hydrated. So I don't really love diuretics if you can avoid it. And if you're using diuretics, then what else could you use besides the diuretic? And if it's for blood pressure, there are many choices. And you could use an angiotensin receptor blocker like valsartan or something like that, or you could use an ACE inhibitor, or you could use any number of different medications that are available, calcium channel blocker. Now, let's just transition into a beta blocker. Many diabetes patients are on beta blockers, and many who have heart disease with diabetes are on beta blockers. Now, beta blockers reduce the risk having a problem with heart failure patients or people with heart disease going into heart failure. So beta blockers can be beneficial for that. But there was an interesting study that came out April 6, 2018. I don't know the exact date, but it was April 6, 2018. So I do know the exact date.
How do you know this? How do you keep this stuff in your head?
It showed that beta blockers, and they were trying to show that beta blockers were beneficial in diabetes patients, especially those that had heart disease. What it actually showed was that there was a 55 to 65% increased risk with using beta blockers in those who had diabetes, and then it went up to 65% in those who had heart disease and diabetes of mortality. Wow. And yet you'll find many diabetes patients on beta blockers. And what do beta blockers do? They can also cause the A1C to go too high, cause the A1C to go too low. You can't read it. So if you want to talk about hidden diabetes, check if you're on a beta blocker. But beta blockers are a dangerous thing for patients who have diabetes, or at least according to this study. And it was published and then printed in Medscape, which is one of those websites that we use as physicians to look at the research as well, and then we go directly to the research. But it's really interesting stuff. And people use beta blockers all the time, and they think it's beneficial. But in this case, with diabetes patients, they really shouldn't be using beta blockers.
Okay. Wow, that's interesting. That's incredible. That's interesting.
But let me say one more thing. Ask your doctor. Don't change. Right. Ask your doctor. If you're on a beta blocker, don't just stop. Don't just stop. Ask your doctor.
Excellent.
That's what we always say first.
Always.
Question.
No, but I want to make sure that you understand this, because this one's a shocking one to me. When I read this was shocking to me. And what's amazing is that it doesn't seem like the alarms are being rung. Yeah, about this.
Wow, that's scary. That's crazy. Well, great question, Anita. Thank you, doctor, for explaining that. That's very, very interesting. We have another question from Kathy Anderson. She's a plant-based Chico member here in Chico. Kathy asks, who has also lost 180 pounds as part of her journey. Kathy was in a wheelchair. She's been a guest speaker at a plant-based Chico meeting. She was in a wheelchair, confined to a wheelchair, no mobility, and she's lost 180 pounds. She's plant-based and going strong. She's doing great. So she asks, I always thought being plant-based, I needed to take B12. My doctor suggests getting the B12 shot monthly because it metabolizes better. Is this true?
And I'm just going to add, hang on, I'm going to add one piece because there was a question that went through the feed. What would cause too high a B12?
Okay, so we got two. You get a two per doctor.
Take it away.
One of those Rodney Dangerfield questions.
Right. Part 1, part 2, part 3.
Right.
So in terms of B12, we used to think that you needed to take B12 as plant-based if you weren't eating any animal products. And it's not actually true, because I just looked at my soy milk the other day. It was funny. I was just looking at the label. But 50% of the B12 is in a glass of soy milk. Now, not necessarily that you're drinking a glass of soy milk, but you put it in the smoothie or you put it anywhere else and you start adding up. But certain foods are fortified with B12. So it's not like we don't get exposure to B12 if we don't eat meats anymore, because companies that make foods that don't have meats in them have gotten smarter, and they've added in supplemental B12. Now, in terms of which is better or a faster route, if you got a monthly injection of B12, yes, that would be absorbed better than if you took it orally. Having said that, that's because you're avoiding the first pass system, or the liver, which breaks down part of the B12. So if you get an injection of B12 once a month, it's the best way of getting B12. Second best is sublingual, putting it under your tongue, and third best is taking it orally. But I find that people don't really need an injection, and taking it orally, 500 micrograms to 1,000 micrograms is plenty of B12, and you can get that orally. Now, your B12 can go too high, but it doesn't seem to be like a high risk factor, but you don't want it really to be off the charts. So if it does go too high, back off the B12 and take it every other day, or take it once a week, and see if you can get the B12 levels. But the B12 levels are tricky, because you want to use the European standards, and the American standards say that somewhere between 200 or 250 at the bottom. No, it really should be around 550 to about 1,500. And some labs have caught up to that and started making it 450, 500, and it goes up to 1450. But really, you should follow the European standards of B12.
Okay. All right. We've got one more question, because we're kind of over. So
we are over.
Linda Ovist wanted to know, she said, my triglycerides went way up. Is there any suggestions of what I could do to my diet?
Yeah, beat it up. Blame your diet. That's good. No. Triglycerides are based on a lot of sugars.
Right.
And the sugars that can be hidden are also starchy vegetables and grains.
Right.
And so you want to try to reduce that because you're obviously more sensitive to that. And triglycerides can be reversed significantly in 4 to 5 days because they're really not a long-term measurement. They're a 4 to 5 day measurement. So if you change in 4 to 5 days from having no starchy vegetables or grains and no sugars and candies and cakes, but I'm giving you guys the benefit of saying we're not eating that crap. We're on the plant-based, and when you're on the plant-based and you have a sensitivity to triglycerides and you have too much of that, they go up. So if you eliminate that for 5 days, you'll see the number come down, and if it's 300, you can see it come down by 200 points in 4 to 5 days.
Wow.
On that note, Dr. Duniaef, my uncle had his triglycerides were over 2,000. Yeah, 2,000. He completely removed all refined grains from his diet and fruits, and his triglycerides came down, but it was the removal of the refined grains that really did the trick for him to get his triglycerides down.
Right. And it depends on your sensitivity. Even sometimes, and I don't mean to push this, but sometimes even whole grains can have that effect. It depends on the person. I always say no body is the same.
Right.
So we don't all metabolize the same way.
Well, and it's like we talk about this in the Starch Queens program. Like as you start to lose weight and you're reversing a lot of health issues, you start to peel back the onion. It's like an onion, the layers of an onion. And you find, like for me, I didn't realize how salt sensitive I was. I mean, my whole life. And now I know. I mean, like a little bit of salt in my body and it sends me over the edge in terms of high blood pressure. Nancy, caffeine. That caffeine, she can't have it.
Right.
So it took her a long time. And again, it's peeling back these layers of figuring out how your body is different than somebody else's.
Right. And everybody metabolizes differently, even in the same family. Right. It's not just because you have similar genes doesn't mean you metabolize exactly the same way.
What your metabolism is going to run at a different rate based on the percent of muscle you have to the fat percent that you have. So a higher lean body,
but it's
slower.
That's true, and you can make a generalization there, but there's so many sensitivities. So let me give you an idea. When I was 20, I had 7% body fat, but my cholesterol was over 200. How's that possible?
Wow.
So it's not just based on the fat.
Right.
Nope. We're all different. We're all unique.
Right. Right.
Exactly. On that note,
I want to thank you, Dr. Duniaef, for joining the Starch Queens on Talking Tuesday tonight. This is a great topic. Diabetes is chronic, running rampant in the United States.
Yeah.
It's
right.
It's
right. Well, when I said in the beginning, we've tripled the diabetes rate. We've tripled the diabetes rate, and that is really what's that?
I said it's unacceptable. It's tragic.
Yeah.
I think about the whole industry around diabetes, the whole, all of the.
But here's the thing. Here's the thing. Don't blame the patient for diabetes. Don't ever blame the patient. Don't blame yourself for it. That's not the right thing to do. And
but they are responsible.
No.
Don't put the blame. Don't blame them, but they are responsible.
Well,
they have to take responsibility for their own
actions. They have to take an active role.
Mm-hmm.
But that means that they may do well and they'll do better. But it doesn't guarantee 100% that they're going to be non-diabetic and it's the easiest thing in the world because, like I said, no body is the same. Right. And we don't know that. And the patients I have get great results. But then again, those are the patients who are coming to me. So I have a bias when I'm looking at these patients. So I don't really know if there are patients who wouldn't respond because they don't necessarily come to me. So I wouldn't know. I'm only searching out the people who come to me.
Right.
So I'm not searching out for it.
Fair point.
That's true. That's very
and
true.
So don't ever use the excuse. And it really scares me when it comes to health insurance and things like that. And people say things like, oh, well, we want to reward the people who are doing healthy things as opposed to the people who are sick. And it's not like the people who have diseases wanted those diseases, right. Nor does someone else who eats this end up with this disease. Someone who eats this may never end up with this disease. Someone else who eats the cookies may end up with the disease. So it's not necessarily equal.
Right.
So, so that's why I'm saying don't point the finger. And so if you get to eat that cookie once a day, which I doubt, but if you get to eat that cookie once a day versus somebody who can only eat it once a week versus somebody who can only eat it once a month versus somebody who can't eat it at all, it's not quite equal.
Right.
And so when you say take responsibility, it's not so easy when the environment out there says eat a cookie. Right. I'm a cookie monster. I grew up with Cookie Monster.
Yeah, we all did.
We all did.
Yes. But you see what I'm saying?
Yeah.
Yeah.
Don't
Definitely.
blame the patient. Don't blame yourself. And don't blame anybody if you fall off the wagon. Just pick yourself up and keep going. Don't blame anybody. Don't point the finger at yourself.
Because gotta love yourself. That's my starch queen.
That's key. That's key. Right.
Love yourself. Yeah, everybody, we are just out of time. We thank you for joining tonight. Love yourself. Have a wonderful evening. We want to thank Dr. Duniaef for joining us again this month for Talking Tuesdays with the Starch Queens. We are so grateful. Will you be coming back, Dr. Duniaef? We would love to have you back.
I don't know. Are you going to bake me some cookies?
I'll send you some muffins.
That was a joke. That was a joke.
I would say, sure. I was just running through my head of all the wonderful plant-based recipes for cookies.
Right. Yes, that's a bad vegan diet. There we go. Just because it's a vegan cookie doesn't mean it's a good cookie.
No. Ours are good.
Ours are good. Ours are qualified good.
Okay.
All right, everybody, good night. Thank you. If you're interested in our program, check us out at www.sqweightloss.com. And thank you for joining. Have a wonderful evening.
Thank you. Good night. Good night, John Boy. And don't forget Medical Compass. Medical Compass. No.
medicalcompassmd.com.
All right. And to connect with Dr. Duniaef.
Or you can just type in my name.
Medical Compass is easier, please.
Fine. Medical Compass MD. You got to have the MD after it because you're not going to find me there. I tried for Medical Compass, but it was already taken.
Darn it.
So the MD wasn't put there. The MD wasn't put there because of ego. The MD was put there to separate out my website.
All right. Well, we got it. medicalcompassmd.com. Good night, John Boy.
Good night, Mary Ellen.